And here we go again. Okay, so basically we've done a little bit about rational medicine use, and I'm saying a little bit because it really is only a very little, small, minute amount. So rational medicine use itself is actually a huge topic, so it really is only a start. I'm trying to get you guys started on the idea of rational medicine use, and to give you an idea. But there's much more to it, and if you want to know more about it, especially going forward, and especially knowing that it's so important in South Africa, consider doing rational medicine use as your fourth elective. So now we're moving over to dermatology, and dermatology has been revised a lot, so a lot of the topics in dermatology has been removed. So only through looking at the videos you'll probably figure out which ones. Content, what are we going to go over in this? Let's just quickly give you an idea here. You must be able to, okay, so all of your outcomes are listed here. Not all of your outcomes, but a bunch of your outcomes are listed here. List fungal skin diseases, list several different kinds of fungal skin diseases, explain the pathophysiology of acne, elaborate on on the treatment of all skin infections with a microbial origin. That's stated very badly there actually. So but now there's quite a few diseases that are actually from bacteria or from viruses or even from parasitic infections as well. So we'll go over all of those in due course. List the common origins of warts, so where you actually get them, explain the treatment of warts, how you get rid of them, etc. I think this is pretty self-explanatory. And as we go forward, and as I place emphasis on different kinds of things or different topics of the work, and I explain and explain and I re-explain something, it probably becomes more and more important. I'm not doing it for no reason at all. The resources for this, the EML itself. So EML in the dermatology section, you'll find there are about 18 diseases discussed in the primary healthcare or in the primary care guidelines. So those are the ones that I want to concentrate on most. We won't discuss all of them, but we will discuss most of them there. Rangendale, there's a few things in Rangendale listed at least. Psoriasis is there. A bit of atopic eczema is there, etc. But the Rangendale really doesn't cover a lot of the skin diseases or dermatology, dermatosis. That's the right word for a skin disease that we actually see in South Africa. So I didn't use Rangendale itself solely. It's a bit limited for us. And of course, the slides itself. Slides itself would definitely help you a lot. So before you actually get started, I know that you guys have an idea about the dermatology itself or about the skin itself, and you've done a little bit about it in physiology, I hope. But for a quick recap on what the important points are, I would want all of you to know. Go look at those two videos. A little bit childish, but actually amazing. So the things they actually put across to you in there will definitely help you understand a little about the function of the skin and how all of different components actually work inside the skin. I'm going to go over them as well, but of course I'm doing it in a much more scientific or more blunt way. That's kind of entertaining as well, seeing as you guys probably be very tired of listening to me throughout this semester. This slide here, so there's a lot of definitions and a lot of terminology that you will not know when you go into skin diseases itself. So that's why I made a very easy to understand little terminology or little Word document that contains all of the most necessary words like vesicles, valves, bullae, all of these terminology that you've never heard of before, with a very small explanation next to it. So I don't want to go over all of that in the class. It's a bit boring, but I definitely want you to review it, as it is definitely important and it's definitely something that will help you assess skin conditions in the future. And I said bring only your brains and questions. Well, you can always still ask questions. Okay, so here is where we actually start with the skin disease itself. Now let me just see if I can open this thing to the max size. Okay. So on the very top layer, we've got 3 layers of the skin. It's called the epidermis, the dermis, and the hypodermis. So the hypodermis is also called the subcutaneous area. So the hypodermis, you can actually see it's a bunch of fat itself. But anyways, let's start from the very top, the outermost part of your skin. So the outermost part is called the epidermis, and the epidermis is a bunch of different things together. But what I really want you to see is that the epidermis has a stratum corneum on top, and that stratum corneum is actually a collection of a bunch of dead skin cells, which is a very effective barrier in keeping things out of the body. So Stratum Corneum really gives your body most of its barrier ability. And remember, your skin's primary function is to keep things out and to keep other things in. So that's why if you get a coronavirus on your skin, you won't necessarily get infected. But as soon as you get the coronavirus to different orifices or openings elsewhere, you can get infected. The skin itself is an amazing barrier, and that's the main function of the skin, is to keep things out and to keep things in. There's another slide I have on all the different layers within the epidermis itself. But the epidermis, really, I want you to know that it is a barrier. That is the most important function of the epidermis. Then we go to the dermis itself. The dermis itself is a very fibrous layer, so it contains a bunch of different elastins and fibrins and things that give it its structural, not potency, but its structural, what's the right word for this? Integrity. So your skin's mechanical flexibility and strength really comes from the dermis itself. So when you pull it on your skin like this, and the fact that your skin only goes to a certain set or only moves to a certain extent, is because the dermis itself is giving it the strength and the flexibility required to keep it there. And then the subcutaneous fat, not much value there. The subcutaneous fat is simply fat. Fat and, well, a little bit of blood vessels and etc. things in there. And then there's a few things I want to highlight in here. So let's start with the melanocyte. The melanocytes are the cells that produce melanin. And melanin itself is deposited in all these different skin cells, all these corneocytes or keratinocytes. I can't remember which one is which one. On the next slide we'll see. So melanin is the one that really defines your pigment. So you get a lot of different melanin deposited into these skin cells, and that protects these skin cells against UV radiation. We have created a few drugs. We don't actually use them formally, but informally we kind of it's black market things. So we have created drugs that can stimulate the melanocytes to produce more melanin, and then the more melanin will actually just go into different cells and actually cause a person to become darker or browner. So I know a bunch of these beauty queens, I'm not sure what we actually call them, but a lot of people actually inject this, they call it melanotan. I'm not sure what the active ingredient's name is anymore, but they inject that and actually stimulates these melanocytes to produce more melanin, and it actually causes a person to become browner or darker. That's the first thing. And then we have these things called the Langerhans cells here. So the Langerhans cells are very interesting. They're actually a type of dendritocyte cell. So these cells are responsible for seeing infections in the first case. So as soon as maybe you step in a needle and the needle pierces through your skin here, as soon as that physical damage has taken place, these cells can actually detect it, and they can start an immune reaction, and they can start releasing different chemokines and chemomediators. I know you've learned that in pharmacology. I know you know that now. And these chemomediators would actually communicate to the rest of the body to bring more immune cells, bring the eosinophils, bring the macrophages, bring the basophils, bring the monocytes, bring all of them, so we can start an immune reaction, and then we can actually target that foreign invading organism or foreign invading nail, and we can try and destroy it, or we can try and get rid of the foreign materials being injected into this area here. I hope that's making sense. So these Langerhans cells, CD4 receptor positive cells called dendritocytes as well, actually see things, or they see foreign substances or foreign invading organisms of pathogens or objects inside the skins and inside the skin, and they then relay information to the rest of the body to start an immune reaction, and they call a bunch of different immune cells. Then the next receptor I can show you here is the erector pili muscle. And the erector pili muscle is simply a muscle that contracts and it makes the hair stand up straight. If the hair stands up straight, well, there's no real function about it anymore. But I imagine if you've seen a cat and a dog before, and when they get a very big fright, their hair kind of stands straight up. And it's because the erector pili muscle actually has an alpha-1 receptor there. So, when you have a massive fright, your adrenal system causes your adrenal medulla to release a bunch of adrenaline. And you know that the adrenaline will then flow through all of the different different arteries in your different veins. And as it flows through these areas, or through these veins, it will distribute it to all of the erector pili muscles everywhere, and the hair stands up straight. So that's typically what happens when you get very frightened. Your erector pili muscles will shoot up straight, or your hair. Physiologically, anything we have to do here, not really important. eccrine duct and glands. Okay, so that simply refers to the sweat gland itself here. So the sweat gland itself is responsible for producing sweat to cool off your body. And the one I really want to get stuck on now is your follicle, the head of the hair and the follicle here. So these follicles are our main points of entry for a bunch of bacterial infections. And if you think about it, it makes a lot of sense. If you look at this little sweat duct here, this is basically containing water, and water flushes out the system the whole time. But your hair follicle itself contains a bunch of sebum, so oil and a bunch of different things together, and I can't remember what they are, but there's like several things inside sebum. And sebum itself doesn't actually just simply flush out this entire area. Sebum also accumulates here in the sebaceous gland. And that is actually like a little nutrient-rich environment for bacteria to go lodge themselves there and start feeding. So there's a reason why I'm saying this, and we'll get to all of that in a second, hopefully. Or no, we will. But the sebaceous gland itself is actually a nice target for infections to start growing at. And also, there's no barrier here. I mean, the little hair running through here is actually opening up this entire gap. And you know, the bacterial cell is so much smaller than a skin cell. It's like the very, very, very top part of my mouth there. Bacterial cells are extremely tiny, so they can easily move through here and they get lodged inside of the follicle itself and then start an infection. Can I do it with the sweat gland? No, not really. I mean, they can't actually feed on sweat itself. The sweat doesn't have nutrients for them. And also, this system flushes and flushes and flushes the whole time. So the chances of getting it stuck there is just very little. But over here, this system doesn't flush nearly as fast, and the sebaceous gland itself contains, or the sebum itself, is nutritious for bacteria. Not all bacteria, but a bunch of them. And then I think that covers a lot of it. You can see there's this little the blood supply itself is running through the dermis here. The epidermis itself is basically a layer of alive and dead skin cells. Not a lot of blood flow going on through there. And then you have your lymphatic system carrying all of your immune cells, and your lymphatic system is typically what would carry your monocytes and etc. Monocytes, basophils, eosinophils, you name it, to the site here if it's needed, and the site will actually communicate, and the lymphatic system will bring immune cells here. And I think that's all you need to know in this image. I hope it's making sense. I went into a little bit too much detail with some of these things here, but I think if you understand that, you're definitely on the right track. Over here, this slide itself, I don't want you to know all of this. It's far too complicated and it's not really necessary. The only thing I really want you to see here is that all of these, let me just hold on before I go too far. Oh yeah, they start out as keratinocytes and then they become corneocytes, and this is the corny layer. So all of these different layers is now only the epidermis itself. The epidermis itself, when cells start and they start differentiating. So when you get a new skin cell, the skin cell is produced at the very bottom part or the very basal part of your epidermis. So that's towards your dermis, just on top of your dermis itself. Then you start creating your skin cells, and they're called keratinocytes initially. As the keratinocytes age, they will eventually fall off, and they will eventually become these dead skin cells on top, and we call them corneocytes, and that's basically dead skin cells filled with keratin. So that's what gives a lot of the physical barrier function to your body. So when you're touching your skin like this, you're actually touching dead skin. So this top part of your skin is actually dead. Crazy to think about it, but yes. And when you clean your house and you find so much dust in your house, that's actually dead skin cells that have fallen off. So it takes our body about 28 days it takes our body about 28 days to completely recycle skin, not recycle, but to completely start producing a new skin and shedding that new skin cell. So from the keratinocyte being produced down here to actually shedding the corneocyte on top here, it's about 28 days. And that is what creates most of our dust in our houses. It's crazy to put it that way, but genuinely, anyways, but that's us, that's humans. And I hope that's making sense. So this skin turnover here, this 28-day skin turnover rate is very important for some diseases because this changes in a lot of inflammatory cases. So if you have autoimmune destruction of the skin, or if you have Atopic diseases like eczema or atopic dermatitis, those allergic skin diseases, the inflammation would actually cause this differentiation of the skin cells to become faster and faster and faster. Not differentiation, this growth of the skin cells. And then your skin turnover rate will actually change, and that leads to shedding. So that's why you see so much shedding in psoriasis and atopic dermatitis, and there's a bunch more examples as well. And that really is the basics of the skin, how exactly lesions look on the skin, and defining these different lesions on the skin, and where would you come across different lesions like vesicles and etc. That's in your little definition booklet I will give you guys on iCanva. And of course, there is also an online quiz that I want you guys to do, and that online quiz will help you also make sense of how these different lesions look. Knowing and understanding all of it, very difficult. Dermatology is actually very difficult to get a grip on. It's just a very, very, very large module. So I'm doing all of the essentials with you, but I'm not really going into a lot of detail about all of it. And that's it. So let me just quickly pause because this video is already becoming massive, and then we can get started on localized bacterial skin infections. So these are infections that really target the hair follicles themselves, and your favorite is also there, acne. I'll get into that in just a second. Oh, the video is already 16 minutes, my word. I hope you understand so far. Okay, I hope I didn't lose you guys with that first 16 minutes. At least you can pause and just watch it later. Hopefully you guys do that. So, prevent localized bacterial skin infections affecting hair follicles and sebaceous glands. So, if you remember correctly, if you just really look at this, so we're talking about infections that are basically affecting our little follicle here, these sebaceous glands. Actually, the reason why a bunch of bacteria affect this area is because of the sebaceous gland, because it's so nutritious. So, the most common organisms actually, I'm going about this the wrong way. So, firstly, you have to actually understand that we have bacteria living on our skin at all times. So the most common ones that we have living on our skin is Streptococcus, Pyogenes Streptococcus, even Strep pneumoniae, and just think about all Streptococcus. Propionibacterium acnes we also have living on our skin, and Staphylococcus aureus and Staphylococcus epidermidis, etc. So think about Streptococcus, think about Propionibacterium acnes, and think about Staphylococcus. So these three are basically living on our skin at all time. And at this moment, I don't have a skin lesion because of them. But some predisposition factors would actually cause the person to get a skin lesion or a lesion of sorts. And that's what we're going to go into now. So the skin infections that these three cause, all localized bacterial infections to a certain degree. But it's funny, why don't I have a lesion now, but then the 16-year-old had so many pimples, or has so many pimples? I just want to quickly mention this. So we are in equilibrium with our microbiome the whole time. So the microbiome itself is a collection of bacteria, viruses, fungi, etc. living inside and on top of us. So we have a bunch of species living on our skin. We have a bunch of species living inside of us. We are constantly contaminated with them. But it doesn't necessarily mean that it causes an infection for us. We are simply in equilibrium with each other. When do we actually get an infection? So bacterial infections, you need some predispositioning factors. So if a person has a compromised immune system, so HIV would give you a compromised immune system, for example. People undergoing chemotherapy that have compromised immune systems. If we have conditions or we have something that creates an optimal living environment for bacteria, so something like hormonal changes for teenagers who have a lot of androgens, and androgens stimulate the sebaceous glands to produce more sebum. So that creates optimal living conditions for bacteria to actually start growing and thriving and just multiplying like crazy. Poor hygiene, of course, if you have very poor hygiene, you don't actually wash off different bacteria or different plaques of bacteria starting to create a biofilm on your skin, that will also start causing an infection with time. And advanced age, but of course advanced age is also related with compromised immune system, so that should make complete sense to you guys. So let's go into pathophysiology of while basically we're still on localized bacterial skin infections. So initially, your host immune system must be compromised, or not even necessarily compromised, but it must be something causing that little sebum, or that little sebaceous gland, to produce more sebum. Or there must be, or you could simply have a compromised immune system in which your body would actually allow Streptococcus to start multiplying in that area. But let's say, for example, that a Streptococcus or a Staphylococcus entered into the subfollicle itself and entered into the sebaceous gland. The bacteria would there start multiplying and thriving, and then your body would start a humoral immune response. So humoral immune response means that a very general immune response. So you'd release a bunch of histamine, you'd release a bunch of different chemokines, and an inflammatory response would start happening. And as this inflammatory response is happening, there will be cell debris there, cells die in that area, different infiltrates as a bunch of fluid collects there. What fluid is this exactly? Exudates, insulates, can't really remember, hold on. Okay, so the exact type of fluid doesn't really matter, but basically it is, well, if you have swelling, when you have swelling, fluid starts accumulating where the immune cells are distributed. So the immune cells normally cause swelling in different areas. It really depends on the chemokines being released in the area. The chemokines released in the area, think about histamine for example, forces capillary permeability to increase. And if capillary permeability increases, you get more fluid accumulating in the area where the permeability has been increased or where there is an infection, where the histamine is originating from. And then all of these things together starts creating this little ball of, well, a swelling. Let's call it swelling first. But it becomes basically a ball of pus. So the ball of pus, or the ball of exudates, or the ball of, I can't think of a nice word for it. But it's basically a big ball of cell debris, infiltrates, dead skin cells, dead bacterial cells, sebaceous fluids, plasma, etc. that starts accumulating if you have a localized bacterial skin infection. So it starts out like this. And the body also starts creating this pyogenic membrane. So this pyogenic membrane is basically separating the inside of this little ball from the rest of your body. And this pyogenic membrane is like a fibrous cap that your body has started making to protect you from the contents of that skin infection. So the bacteria inside here, the bacteria in the dead skin cells, there's also dead bacteria in the sebum, etc. All of that on this inside here. Still, some of it is still viable, some of it is still alive, and they stay alive for a long period of time. So that's when you cut open a cyst like this, for example, and you don't remove this pyogenic membrane. Some of that living bacteria that's still thriving on these corners here could survive and could reinfect the person or restart a infection. Let me give you another example of what it actually looks like. So initially, it would look like this. Your normal skin, and then you have a Streptococcus and Staphylococcus entering in here, but there's not enough food for them to really thrive, and then they simply die out. But let's say then there is a predispositioning factor like the immune system that isn't activated, and if the immune system isn't activated, they can start multiplying fast in here. When they start multiplying faster and faster and faster in here, they actually start this inflammatory response. So this fluid you're seeing here is basically this dead skin cells, a bunch of dead bacteria, plasma itself from the capillaries here that should be leaking into this area, a bunch of immune cells that are suppressing it inside here, and etc. And if we cannot control this, the bacteria would simply multiply and multiply and multiply and multiply, and eventually you'd get this, a comedone itself. So this is an example of a closed comedone. And or you can get something like this, but this I'll go into a little bit more later. So this is how a cyst starts. Remember, if I go back to this little slide here. Oh, no, wrong slide. This slide here. Oh, maybe this is how a pimple starts. But a pimple can turn into an abscess, can turn into a furuncle, can turn into a boil, can turn into a pustule, can turn into a cyst, can turn into a nodule. So all of these are different versions or different grades of a localized bacterial skin infections. And for example, it really is determined by their size. So a pimple would be extremely small, or a pustule would be small, a cyst would be massive, and a cyst must contain fluid. It must be a certain size, where a nodule doesn't have to contain fluid itself, but can be a solid mass. And all of this, the contents inside here, can also start solidifying with time and won't be leaking like that. And
then you get something else. So look at this little slide here, for example. This is a nice one. So this is early during the infection itself. So that's when you're just getting started. And then when you have an infection starting, these keratinocytes on the side would start shedding, and they would also plug up this area. So dead skin cells, dead bacterial cells, etc. And then the inflammatory response is starting. The inflammatory response starts inflammation in here. And as the inflammation starts, the fluid collects inside here, and different immune cells collect inside here. And with time, this thing grows and grows and grows. And you can see the inflammation is actually growing towards the inside of the skin. And as this inflammation grows towards the inside of the skin, you actually get damaging of the surrounding tissue here. And they can eventually get scarring from this. Okay. I hope the pathogenesis is making sense. I hope that you can see that the bacteria enters and the bacteria starts multiplying, and as the bacteria is multiplying, there's a bunch of inflammatory responses happening, and that inflammatory responses can maybe not completely suppress a boil or a cyst from starting, but as it's happening, this thing is growing. And then eventually you have something like a cyst or a nodule forming. So there really is two versions of this, and I want you guys to think about acne and cysts in a similar way. They are similar in, well, acne, there are cysts in acne, but maybe let me put it a different way. Think about boils and acne in the same sense. The only real big difference is acne is really contained to the back and the face mostly. You can also get it on your shoulders and your chest, but to a lesser degree. And acne is mostly caused by Propionibacterium acnes. Where on the other side, boils and abscesses are mostly caused by strep and staph. Those are the two big differences I want you guys to always remember. They are both, in a certain sense, localized bacterial infections, but as soon as you have 15 different ones all over your face, you can start thinking acne. If you just have one random one sitting somewhere, then you should think boil. And then, before I go too far, let's take a quick break.
Okay, so what do they actually look like, these boils and these cysts? Well, I mean, I think most of you have seen them over the years, but here's a few examples quickly. Can you see there, if you look very closely, you can see there's a little bit of pus surrounding a little hair there. That's a nice example of a boil. Can you see that this entire area here is involved? That's very similar to this over here. So we have a bunch of hair follicles becoming involved. So a boil or a cyst can also grow larger and larger and larger and start involving more and more and more of these follicles as it grows. And there's a little blackhead over there. Anyways, this is still very much contained. If a person starts having an infection, like over here, you can see a nice clear red appearance around it, inflammatory response around it. If this area of the skin becomes very large, so this redness around here becomes very, very large, then you can start assuming that the person actually has a diffuse bacterial infection, or you can actually have something called cellulitis. I'll talk about more of that in just a little bit after localized bacterial infections. But I hope you guys can see that really the follicle starts, and as the follicle swells and grows and more infiltrates go into that area, it starts growing larger and larger and larger and larger and larger. And if they are simply one or two in different areas of the body, then you can definitely think about boils and cysts. If you have a bunch of them putting around like this, you should start thinking acne. But I don't even think this is acne as well. And of course, you don't really get acne on your leg or acne on your butt. You get acne on your face and your back and your chest. So the area itself actually also matters. So all of them start the same way. All cysts, pimples, pustules, etc. start in the hair follicle. And we start classifying them differently according to their size and their appearance. So as they actually change, we start classifying them differently as, for example, a cyst or a pustule or etc. So all of these are quite specified areas, so it's not really diffuse in a big area here. It really is quite specified. This one here I'm actually a little bit concerned about because it has a very large red area around it, so this one's actually probably becoming a little bit diffuse at the moment. Oh, and here is another example I want to also mention. This is called a paronchia. So paronchia is basically like a cyst or like a little abscess, but that is only around the nail bed here. And I'm mentioning this one specially because there is no hair follicle involved here. So this happens at the very corner of the nail bed there. I'm not exactly sure how the bacteria feeds on that area there, but it does, and it happens. So that's also a very difficult thing, not a difficult thing to treat, a very painful thing to have actually. So how do we treat these things? So the first priority would be to remove all of the pus, to drain an abscess or a boil. Why do you think it would be important to drain it? Any ideas? I can't actually see you, so I can't get a reaction. But anyways, if you look over here, that you can see that the pus inside here is very much closed off from the rest of the body. So your body made this pyogenic membrane around it, and it's trying to separate it from the rest of the body. So there is no blood flow happening through this thing. So there is no blood traveling through the cyst itself or through the abscess itself. So if you give a person antibiotic, would you think the antibiotic would actually spread inside of the cyst here? Probably not, because the blood flow just goes around here and around here, but it doesn't actually get distributed into the cyst here. So if there's no blood flow, there's no arteries into the cyst, do you think a treatment would be able to be delivered there? So if I give a person antibiotics against strep and staph, do you think it will actually get to that strep and staph to kill it? No. So do you think it's rational to give it? No. So what is your first priority if you have something like a cyst? To drain it. Without draining it, you probably won't actually get any antibiotic there, so you'll be using antibiotics and antibiotics and antibiotics and antibiotics the whole time, and that cyst will still be alive. Not alive really, but it will still be there, thriving. So first thing first, you have to actually drain the cyst. Remove all of those bacteria and the dead skin cells, all of it from the inside, because if you don't drain it, that for the few bacteria on the inside, they can still take life later on. And if you do drain it and you don't actually remove all of the contents, you can actually get it restarting later on, as the bacteria can still thrive in that area there. So after you removed it, then you can start something like a local antibiotic cream or gel or a lotion, because then they would actually be able to reach all of the areas they have to reach there. It's not an overwhelming infection anymore. Even if you apply a topical antibiotic here, do you think the antibiotic will be absorbed through the pyogenic membrane into the cyst here? Probably not. So once again, you have to remove a cyst first. So the ones I want you guys to know about is mupirocin, bacitracin, neomycin, polymyxin B, etc. Will I actually ask you these names? Maybe in a recall sense. I wouldn't ask you to explain the mechanism of action. You guys will only be doing antibiotics in PHC 313. But I want you to at least know about them. You've actually used them before. Your mothers have probably used them on you, or you've been nurses probably used some of it on you. Mepirocin, the other name for it is Bactroban or Supiroban. Bacitracin, the other word for it is, I can't remember. Silver sulfadiazine is Silbercore. Neomycin, can't remember. Polymyxin B, also can't remember. So we won't actually use all of these. The ones we mostly use are mepirocin and sulfur sulfadiazine. So these are all local, no, what do you call it? Local antibiotic creams or gels or lotions. Mechanism wise, I wouldn't expect you to know the mechanism. I just want you to think about them for now. So this is really there to stimulate your thought process, but not really something I would ask you in the test in a very difficult fashion. I might ask you to say, what cream can we use for a abscess or boil that's recently been drained? And you can say mepirocin. So when are systemic antibiotics indicated? So systemic antibiotics only become indicated when this area becomes more diffuse. So the swelling here is actually involving the surrounding area. So there is symptoms of cellulitis. So cellulitis is simply a skin infection, a diffuse skin infection. And if you have this and some of this, is it not the cervical nodes? You have a high temperature, for example, you have fever, you have systemic symptoms of infection. So if you have a diffuse infection surrounding something like a boil, and you have systemic symptoms like fever, white cell count, high CRP, then we start thinking, okay, now we have to actually start using systemic antibiotics, because this bacteria is spreading through this person. So there's a bunch of different treatments that we use or there's a bunch of different antibiotics out there. So how do we know which one is the right one to choose? This really comes back to rational again. So rational medicine use. What would rationally be the best one to use? Would we use a broad spectrum or narrow spectrum? Would we use something that kills all the bacteria, even the microbiome bacteria, or would we use something that's very specific for only that bacteria? So of course we would want as specific as possible, and that's why we always say, as part of rational medicine use, we use the most narrow spectrum possible. with the least side effects, the cheapest relatively, and freely available. So all of these are tied in with your rational medicine use principles. More of this in 313 once again. Then I have this little slide here from your Rangendale, and this is also what you'll be doing in PHC 313, but I want to mention it because these are the drugs that you should know about for skin infections and treating skin infections. So we've got flucloxacillin, azithromycin, and clindamycin. The class themselves you can read there. I'm not going to go into that. We don't have enough time to go into all of that and how they actually work. But these are generally the ones that we use for gram-positive in skin infections. And there is also cefuroxime that's not inside here. Cefuroxime is also something we use commonly for skin infections because it's so good against gram-positive infections, gram-positive skin infections. And can you remember what gram-positive actually means? Probably not, but gram-positive is, well, all three of these are gram-positive. I'm not actually sure about Propionibacterium acnes, but the important thing about Propionibacterium acnes is that it is a anaerobe, so there's a very few specific drugs that work very well against it. Once again, there is a differentiation between staph and strep and Propionibacterium acnes. That's why I highlighted it in red. So acne, boils, acne, boils. Okay. So this slide here, I wouldn't really ask you a lot from this slide here. I might actually do something like give you all of this information in a test, and then I would ask you which one is rationally the best one to use for a boil. And then if you're thinking rational medicine use, you have to think which one is the most narrow spectrum, like I told you in the slide right here. And then you say, oh my word, but only gram-positive, that makes so much sense. And it has very good skin penetration. That means it's going to get into the skin the best way possible. Clindamycin has the best skin penetration, but it has all of the different ones it's also targeting. So it's targeting gram-negative and anaerobes. We don't need to cover gram-negatives and anaerobes because we know it's staph or strep. So this is definitely not what we want to do. This is what we want to do. This is the most rational one to use. So I would maybe give you the information like this, and I would ask you, according to you, which one would be the best one to treat a localized skin infection that is starting to become systemic with a person having a fever of 39. And then I would want you to interpret this in terms of rational medicine use. And I told you already that most rational thing in antibiotics is the most narrow spectrum possible. And yes, but that is a bit of a high level question, so don't expect too many of those kinds of questions from me. If I do ask you a question like that, I would probably make it very obvious. Topical treatments, okay, so these are simply the topical antibiotics that we use. Once again, not something that we can be covering now in a lot of detail, so just know about it for now. And yes, that's what I can say, more or less. This is argyria. So if you use too much sulfur sulfadiazine, you start getting argyria and you start becoming blue. Silver deposits make you blue. If you want to be Papa Smurf, then it makes absolute sense. And then let's take a quick break here, because I do think I still need to discuss some of this with you, but I'm not sure to what extent. So let me just ponder on it for a little while. Ponder on it. Okay, so I've pondered on it for a while, and I've left you guys some of you in argyria. All of these I do want you to know in a certain degree, but I won't ask you to actually memorize these tables. So if I do ask you something like this, I would actually give you the table, and I would ask you, according to you, which one would be the best to use for a person with, actually not this table, for a person with a penicillin allergy. Then you can't use flucloxacillin because the person is allergic to penicillin, so this one is out. Then you don't want to use one with a very broad spectrum like gram-positive, negative, and anaerobe, so streptomycin is also out, so then you can go for azithromycin. But I won't actually expect you to memorize these data, this information. I would simply give you all of the information and tell you what would be the most rational thing to do, and then I would want you to choose the most rational option. So that's something I might do, but asking all of those details, no chance. Also, I have this little slide here that just explains some of the mechanism of some of those drugs you just saw. So in not most of the cases, but with antibacterials, we generally something is targeted, like the protein synthesis or the cell wall synthesis or something of the sort. So somewhere along the line, we want to inhibit those proteins being made, so that when these bacteria want to undergo mitosis from when they're 1 to 2, they can't, because they can't actually produce those
functional proteins they need inside of their cells to do things, or they can't produce their cell walls. If they don't have a cell wall, they can't protect themselves from everything outside the environment. They can't protect themselves against the immune system, etc. So, but you'll do a lot of that in 313, so that's not our responsibility in this course. In this course, we talk about dermatology. So the only thing I've really gone into so far is localized bacterial skin infections, and by that I mean boils and abscesses and pustules, all of the things that are caused by staph and strep. The next one I'm going into is acne, and acne is caused by, remember, Propionibacterium acnes. So it was, where did I put it? Where did I put it? I think it was this one, this slide here. So the other two are gram-positive bacteria. What you need to know about Propionibacterium acnes is that it is very, very strict anaerobe, so meaning it grows in oxygen-poor environments. So all of us have it on our skins at all given times. I mean, you have it in your follicles right now, eating away your sebaceous glands, or your sebum inside the sebaceous glands. But it's not actually causing an infection at this moment. And for who would it start causing an infection? Let's talk about the predisposition to people. So generally speaking, teenagers. So adolescent people. So when you are an adolescent, you have a big flux of androgens, testosterone, and then on the other side, estrogen and progesterone. So teenage girls and teenage boys both suffer the same thing. Generally speaking, the teenage boys do suffer a little bit more because they have more testosterone. And the androgens are the receptors on, or they are androgenic receptors on our sebaceous glands that, when stimulated, forces the gland to produce more sebum. So, all of us have Propionibacterium acnes on our skins. But if you give it more food, it can start thriving. If it thrives, it starts making more and more copies of itself. And eventually, there's so many of them there that the immune system can't ignore it anymore. The immune system launches an attack against it. And then, when this attack is launched, we get the swelling. You can see that there is a little bump there. You can see that the raised cyst there. But you can see that it's growing bigger and bigger and bigger. So that's when the Propionibacterium acnes is just thriving so much in that environment. And the inflammatory response is started and continually launched against it. But it's never completely winning the fight. That's why you actually have acne. Later on, when you get older and your hormonal fluctuations stop, you have less androgenic receptor stimulation. But androgenic receptor stimulation is actually a part of testosterone. But that also happens with progesterone and estrogen, but to a lesser degree. But if you have massive amounts of estrogen and progesterone, they can also stimulate the androgenic receptor. And also to mention on that, if you have a massive amount of estrogen, you will most likely also have a larger amount of testosterone. So some of the estrogen in women are converted to testosterone, and some of the testosterone in men are converted into estrogen. So if you have a lot of one, you would probably have relatively more of the other one as well. And that's what I want to mention about that. There is a little bit of information just for interest sake here about the aromatase enzyme that converts testosterone to estrogen, and I think I've discussed most of this already. This slide here, don't worry about it. This slide was basically about how estradiol is made, and the only reason I put it here is to show you just how similar is testosterone and estradiol are to each other, or how similar all hormones in our body are made. Not all hormones, but a lot of hormones made from cholesterol. So slight changes, massive results. So even if estrogen and testosterone are vastly different with what they actually give you, the structures are quite similar. So if you have large amounts of estrogen, they can also stimulate those androgenic receptors, like I told you guys. But you're doing more of that in endocrine, so that's not really what we're going into now. What we're going into is acne, the treatment of acne. What I also want to mention here about the grades is just I want you to know that the grades are worse as you go up in grades. So grade 1 not bad, grade 2 a bit worse, grade 3 even worse, grade 4 oh my word, your face is exploding with big cysts. So the only thing you have to know about the grades is just that it gets worse with the grades going up. And then when you are in a grade 4, you most likely will have that scarring that also happens because of acne. And then here we have also, this is also in a certain sense related to the grading itself. So there's little whiteheads there, then you have blackheads. So whiteheads themselves aren't issues. Blackheads can also become whiteheads, or can actually become clogged and become a papule. And as the papule, inflammation in the papule is growing and growing and growing, you form a pustule. So a pustule is what we also call a pimple. As the pustule is also growing and growing and growing, inside there you'll have a um, fluid buildup, and that fluid buildup will make this a cyst. And if the cyst becomes kind of nodular, we call it a nodule. And just for interest, I can put that out for you guys. And also you can see cysts can be larger than 0.5 meters in diameter, so quite large. And I think you understand the idea. If we go up in grades, we're probably going up in acne severity. So the pathophysiology is very much the same as you get in a boil, but it's just now that we're talking about Propionibacterium acnes in anaerobic environments, not about staph and strep anymore. And what you can basically see is that as we're getting this plug here, this plug forming, the bacteria can start thriving and thriving and thriving. As this bacteria thrives and thrives and thrives, inflammation starts in the area. And when inflammation starts, we know that all of the cytokines draw more and more immune cells to the fray, and also causes capillary permeability to go up, so fluid also leaks into the area, so more plasma accumulates there. And eventually you have this big fluid containing bulb, which is a bunch of sebum, bacteria, immune cells, etc. And this one is completely shut off from oxygen, so these bacteria can just thrive and thrive and thrive. And then as it's growing and growing and growing, the inflammation is also going towards the inside of the skin, so into your dermis. And as this is happening, you get acne scarring, and that's why you'll get this eventually, this acne scarring. Okay, I think I've mentioned what I want to mention. So the mechanism or the pathophysiology, let's start with that next.
Okay, so how do we actually get acne? So what is the process? How does our body actually start forming those pimples and pustules, etc.? So first step is, well, actually no. First step is we have androgenic stimulation of our sebaceous glands. So this means that most likely testosterone is in excess, and testosterone is actually stimulating the sebaceous glands. And this could be dihydrotestosterone, or it can even be a big amount of progesterone that stimulates the sebaceous glands. It's mostly those two. But I want you guys to always think about testosterone and androgenic stimulation of the sebaceous glands. So after that happens, the sebaceous glands start producing more and more and more sebum. And as they produce more and more sebum, you start getting plugging of this of the follicle itself. So this is because of the skin cells shedding in the inside. We call that desquamation. So as you produce a lot of sebum, as you overstimulate these sebaceous glands, they produce more and more sebum. And as this happens, you also get this abnormal desquamation, meaning that your skin cells on the inside of your follicle abnormally shed off. And as you have this combination of both of those, you start forming a plug in the follicle itself. Once this plug is formed, that Propionibacterium acnes that is already on your skin has the perfect conditions to start thriving. So now it's undergoing mitosis faster and faster and faster and faster. It's making more of itself at an extreme rate. And then this starts, this growth of this, this growth of P. acnes itself leads to inflammation. So as the inflammation is actually happening, we get a closed comedome forming. So that abnormal follicular keratinization or in desquamation, so the abnormal growth of the keratinocytes inside the follicle that's caused by inflammation, and the abnormal shedding of the keratinocytes inside the follicle leads to a closed comedome forming. So just a whitehead, you can actually say. And after this has happened, the big mass of P. acnes also starts releasing bioactive mediators. So what that means is it's basically proteolytic enzymes that break apart a bunch of the cells on the inside. So we have an immune reaction against the P. acnes in the first case. And as the P. acnes is releasing these proteolytic enzymes, which we actually have more inflammation happening. So we have inflammation directly due to P. acnes, and the P. acnes actually damages the surrounding tissue. So eventually this leads to a massive amount of inflammation. And as this massive amount of inflammation just grows and grows and grows, as this P. acnes thrives and thrives and thrives, we get follicular wall damage. So this refers to something like this image here. So these follicular walls actually become damaged, and the pimple starts spreading and becoming bigger and bigger and bigger until you have something like this here, a cyst or a nodule that's actually surrounding a bunch of different follicles and has caused inflammation in a bunch of different follicles there all together, forming one single massive nodule. So I tried to kind of just give you some explanation of all of these processes, but if you understand this process here, you are more or less on the right track. And what I want you to see now is that when we actually treat acne, we try to prevent or change all of those processes that led to the nodule forming. So, in the very first thing, what was the first problem we have? Too much sebum. So, can we actually limit testosterone or progesterone? Not really. If you limit it in a guy, you would probably turn him into you'll make him more girl-like. So if you limit androgen in men, they become less manly in a certain sense. We can in women limit the androgen receptor stimulation by actually giving them the oral contraceptive tablets. But I'm not going into that too much with you guys because it is actually a part of your endocrine. So I want you to know about it, and it can actually help for pimples, but exactly how, you do it later on. But generally speaking, we're just replacing that progesterone your body would have made with a progesterone that doesn't have so much androgenic activity, so it doesn't stimulate those receptors as much. So you basically get, I'm going into too much detail, but you get hypothalamus pituitary axis suppression of your own progesterone, and then you replace that progesterone with a progesterone that doesn't stimulate the sebaceous glands, and you make less sebum. Don't have to know that, just wanted to put it out there. We can try and prevent the closed comedone from actually forming, so we can lessen the follicular keratinization and desquamation, so the abnormal growth of keratinocytes within the follicle and the abnormal shedding of keratinocytes within the follicle. Because remember, as they're shedding, they're plugging this hole, so we want to prevent this abnormal keratinization and desquamation, abnormal growth and shedding of skin cells. Same thing there again, preventing abnormal. And then another thing we can also do is we could try and lessen the growth of the bacterial infection, the inflammation. So we can do this by decreasing the gland's activity, making less sebum, or we can inhibit the bacteria, so we can actually destroy the bacteria or just make the area more unfavorable for them to grow, and we can then lessen their growth. Because remember, our immune systems are only reacting to the presence of them there. So if we have less of them, we will most likely have less reaction. Less reaction, less pimples. Woo! Okay. So what is the best way to start? So first we can try and lessen the sebum production. So lessening the sebum production, we said we can use something that replaces testosterone, but then we also said we can't really, because rationally, if you remove testosterone for men, they will not really be men anymore. Well, they will still be men mentally, but physically we're taking away the testosterone, gives them the manly traits. So you can't really do that. So what we can do is we can give a person something like a topical retinoid, or isotretinoin and dapalin, and there's a few examples there. So these actually normalize the keratinization. So if we normalize keratinization, we have less of the keratinocytes inside of the cell actually abnormally growing and shedding off. So we have less plug formation. That's the first thing. And then it has a bunch of functions actually. One of the things it also does is it reduces the intrafollicular keratinocyte adhesion. So remember, as these adhere to each other, they form a plug. So if we can just decrease the amount they adhere to each other, we also decrease the amount of plug formation. And then something that's very specific about the retinoids is that they can actually decrease the sebaceous gland size and function, meaning they produce less sebum. If you produce less sebum, we are almost reversing the entire problem, because it was because of the excess sebum production that this entire process started. So if we can just stop that, we've actually stopped a big part of the pathophysiology of acne. And then retinoids themselves are antibacterial to a certain extent, so they do actually damage, or they do actually inhibit the growth of Propionibacterium acnes as well. Topical salicylic acid, I don't think we actually do that much anymore, but generally speaking, they just reduce plug formation. And also the salicylic acid itself is also toxic to the P. acnes itself as well. So we reduce the amount of P. acnes, and we basically just reduce the amount of plug formation, and that's it. So we basically not creating that favorable environment for P. acnes to grow. This one is much better. Topical benzoyl peroxide. This is the one we use a lot in the pharmacy. It's the first line of therapy, cheapest, most accessible. It is actually toxic to the bacteria itself, so it destroys some of the bacteria, and it also it actually enhances desquamation. So if we can enhance desquamation in a controlled manner, we can lessen the amount of abnormal desquamation. So if we lessen the amount of abnormal desquamation, we have less plug formation. So that's basically what we're getting done here. So topical benzoyl peroxide basically kills bacteria to a certain degree, and it also enhances desquamative action, which normalizes desquamation. If we normalize desquamation, we have less abnormal shedding of cells within the follicle. Less shedding of the follicle, the keratinocytes within the follicle, less plug formation. Less plug formation, less acne. Okay, and the limiting, all of this was once again part of what do we call that? Endocrine, so I won't ask you that again. And then we're going into specifically the retinoids themselves. But I first have to catch my breath. So the retinoids themselves are a very, very unique set of drugs. Really not nowhere else they actually fit in. We only use them for skin conditions, so psoriasis mostly, and acne. Very weird that it actually works so well in psoriasis, but it does. I have a little YouTube link in your slideshow for you, and this YouTube link gives you an example of how retinoic acid actually works and where the retinoic acid receptor is. So the retinoic acid receptor is actually intracellularly, and it's a little area in the gene pool, you can say, or a little area of genetic information that becomes stimulated by retinoic acid or by vitamin A. And when we stimulate this, it actually gives us various effects afterwards. So those effects that happen after we alter gene transcription in these cells is normalization of keratinization. So we don't have the abnormal growth of keratinocytes within the follicles anymore. Less growth there, less shedding. Reduced intracellular corneocyte adhesion. So remember, as they adhere to each other, they start forming a thick plug inside the follicle. So if we reduce the amount of adhesion between these corneocytes after they shed, less chance of a plug forming. And then they decrease the sebaceous gland size and function. So this has to do with the retinoic acid receptor on the genes themselves. When we alter the retinoic acid receptor genes, we actually alter how the sebaceous gland is produced and how the sebaceous gland is actually functioning. So as soon as we alter that, we are decreasing the amount of sebaceous sebum produced by the sebaceous gland. So we are decreasing its size and its function by altering the genes that control those functions in those cells. And then, of course, it's antibacterial to a certain degree. But I want you to understand that all of this is happening within the cell itself. So there's an intracellular receptor somewhere in the nucleus, and when that receptor is activated, it's actually like a little coding there. When that receptor, the coding there, is activated by retinoic acid or by isotretinoin, all of these effects happen afterwards. So these are the pharmacological effects that happen, and this is an intracellular receptor itself. Okay, I hope that's making sense. It's part of the RXR family. So these activation sites, the binding sites, are called retinoic acid receptor alpha and beta. There's a bit more that also goes on with it, but there must be a limit to how much we actually ask of you guys. So for me, if you just know the retinoic acid receptor is intracellularly, that's fine. I don't really want you to understand these isoforms because there's different kinds of it. Like there's alpha 1, alpha 2, and alpha 1, alpha 2 receptor, beta 1, beta 2, beta 3 receptor. Same idea, but I don't really want you to know that. It won't actually aid you guys in understanding anything for acne at this point. And then, yes, that's it. So that's more or less the mechanism of action. There's probably a lot more going on in there. Do I want you to know more? No, it won't help you in any clinical duty. So pharmacologically, I want you to know these are retinoic acid receptor binding proteins. Retinoic acid. These isotretinoids act on retinoic acid receptors within the cell's nucleus, and then when they are activated or when they bind to these receptors, they have effects A, B, C, D, like in the previous slide. That should be good enough. Okay. And then why these effects actually counteract acne? Probably also important. So if I ask you, what's the role of using andapalene in acne treatment? Then you should be able to tell me. So here are a few examples. I want you to know tretinoin and andapalene. If you know those two, I'm probably very happy with you. And yes. Oh, of course, you're seeing this pregnancy category here and you're seeing X and X. That's because the isotretinoins are extremely teratogenic, so never ever use. Where do I want to go with this one? Okay, so we've covered acne a little bit now. We've covered a few drugs used in acne, and I'll be covering isotretinoin specifically a little bit more because isotretinoin is the mainstay therapy or the number one therapy for acne itself. What I want you to know about it, especially important, is that it is teratogenic. So if a person is pregnant or wants to become pregnant, no go. It's an absolute no go drug. Rational medicine use, of course, if you're giving isotretinoin to a person who wants to become pregnant, completely irrational, because we don't know if it's just one dose or 3 doses or 5 months worth of doses that actually causes teratogenic effects. But we know that it's teratogenic, so do you want to take that chance? Obviously not. Okay. A few contraindications here. Hepatic insufficiency, it has to do with the cytochrome 2b6y or something like that gene. Not really something you see a lot, but hepatic insufficiency, generally speaking, we actually test the ALT beforehand. So the ALT is a basic liver function test. We test that beforehand just to make sure that the person's liver isn't actually damaged or inflamed for some reason or undergoing some damage because of some other disease before we actually start a person on isotretinoin. Then, of course, hyperlipidemia or cholesterolemia, or the other word for it was also dyslipidemia. So, isotretinoin has a tendency to increase your lipids. So that you would know, I hope you know, that the higher your lipids go, the more likely you would actually get atherosclerosis, and the more likely you would get coronary artery disease later on. Because if you have more lipids in your bloodstream, your chance of developing blood clots, or let me just call it atheromas rather, increases. So that's also a contraindication. And then hypothyroidism. So hypothyroidism refers to a decreased amount of thyroid hormone in your bloodstream. If you have a decreased amount of thyroid hormone in your bloodstream, this isotretinoin could worsen that. And if you do actually worsen it, there's a certain disease, I just can't remember the name now, that might actually happen. But just know, hypothyroidism is a contraindication for the use of isotretinoin. And then I specifically highlighted the fact that you cannot use isotretinoin with tetracyclines. That's because when they're used together, you can actually get an increased intracranial pressure. So the pressure inside of your brain could actually increase. And that could lead to seizures and or strokes as well. So that's definitely something we don't want. And I'm mentioning this because a lot of the times in the private sector, you would get people started on tetracycline antibiotics for their acne, and then they would escalate them later on to isotretinoin. And when you start using isotretinoin, your acne doesn't just disappear overnight. It takes quite a while, and because your face is becoming drier, there's actually a big chance that your acne seems worse initially. So if people then start taking tetracyclines because it works so much faster for them, and they actually have both of these drugs in the systemic circulation, you have a big risk of getting an increase in the cranial pressure, which could be deadly. So definitely something to check out for, especially if people were using antibiotics for their acne, because the antibiotic they were using was most likely a tetracyclic antibiotic, tetracycline for example. Then we have some dose-related side effects here. Cellulitis, xerosis, blepharoconjunctivitis. So I think cellulitis is dry lips or dry and cracked lips. Xerosis is dry skin, and blepharoconjunctivitis is dry eyes. What I want you to see is that generally speaking, your skin becomes drier as you use more and more of the drug. Some myalgia, some muscle pain, some alopecia, meaning some hair loss, and increased susceptibility to staphylococcus infections. So that will just be something that you have to watch out for. So I mean, that's not something that's contraindicated, but it's something that can happen. And if it does happen, you just have to be aware that this patient most likely is getting a new boil somewhere. Raised plasma lipids. So if you already had hyperlipidemia or dyslipidemia, you will be worsening it. If you worsen it, your chances of getting atherosclerosis is increasing. If you already had hyperthyroidism and we give you isotretinoin, we will worsen your hyperthyroidism. And there is a reason why it was so important. I just can't remember what it's called now. But if you have a severe hyperthyroidism, it can actually also be deadly. I just can't remember what you call that one. Malaise, a feeling of tiredness, depression. Not sure if it's depression because of the drug or it's depression because of that stage in your life, because we normally use these for young people, so maybe it's depressed time in their lives. But anyways, be aware that this drug is paired with depression at the very least. Hepatitis, meaning liver inflammation, and photosensitivity, meaning your skin is sensitive to the sun. Whew, a lot of words. I hope you guys are still following me, and I hope this way of class is still working, and I will still release an assessment asking you to just tell me what I should do for you in these classes, and hopefully that can also help us a little bit. Clinical data and monitoring for retinoids. So retinoid, there's a dosage there. Do I expect you to know dosages? No. If we had a case lab examination, yes. Or in PACE, if you give me a care plan filled in, of course yes. So but for now, doesn't really matter. I don't care if you know the doses yet, but eventually you must know the doses. Or if you actually provide care to a patient, of course you have to have the right dose then. Will I go into all of this now? Not really. The only thing interesting I want to mention here is maybe that the absorption is increased with a fatty meal, which I always think is so interesting. So you have to eat your McDonald's with your isotretinoin. Very effective against severe acne, improvement in 1 to 3 months, and then there's only about a 33% of people who relapse, but generally speaking, a lot of people don't actually relapse, meaning that once you use isotretinoin, it's a very big chance that you won't have to use it again. But some people have such severe acne that they still need to use it for another cause. And some people still don't get the treatment or the outcomes they want. And then here it is important. Before you start a person on isotretinoin, you have to do liver function tests. So that's the ALT I was talking about, just to see if there is some damage or something stressing the liver out to a certain degree. And you have to see if the person has hyperthyroidism before you start them on isotretinoin. Also, it's not important. Acne, isotretinoin, betaxotine. So these two really come in with psoriasis, but psoriasis we are limiting to a certain degree as well. Antibiotics used in acne. So remember, we want to limit the amount of Propionibacterium bacterium acnes that's proliferating. So we can do tetracyclines or clindamycin. Tetracyclines we can do systemic, and clindamycin we can do topical. And works on the 50S ribosomal subunit and disrupts protein synthesis. This is tetracyclines. Clindamycin itself works on the 50S subunit. That's a macrolide. But once again, PHC 313, not really now. Here's a few examples I want you to know about, and the most important thing I want you to know about the antibiotic now is that tetracycline interacts with isotretinoin, and if they interact, we can get a severe side effect from it. So that's what I definitely want you to know for now. This information here, I mean, definitely I would want to know it if I was you, but I wouldn't actually test you on it necessarily. So we can just skip through that. And then when young people actually use tetracyclines, they get these beautiful teeth, not something you would want. And that stops localized bacterial infections. So we've covered now boils, abscesses, bronchias, and acne. And we are moving on to diffuse bacterial skin infections. But I think this video is becoming very long, so I think I'll just make another one, and then you can view this one later on, or view them different times. The next section of the work is about diffuse bacterial skin infections. So we're not focusing only on the follicle anymore, we're spreading out. So we're not just there, we're going outwards now. And then I will also review that little terminology guide I have for you guys, and I'll probably have to upload it as well. Anyways, next video is coming soon. Let me just find the pause button and pause.